Hey guys, my name is Keisha Valdivieso. Today I'm with Steven Salinger. He's an officer of the Gunstead Club and I'm an officer in training. And today we will be talking about ilium pushes. Normally, if we were in campus, we will be talking about the lectures and the information part for like 5 minutes, and then the rest of the time it would be hands-on. But since the situation with COVID, we are no longer able to do that in person. So what we are going to do is talk about the common errors and how to fix them.
All right, so we're going to work on the first common positioning error. This is the patient being laid down too far back on the pelvic bench. We're going to start with normal, show you the full motion, and then abnormal and what the error looks like. So if you don't want to go ahead and lay down. All right, so she's very familiar with good patient positioning. Let's go ahead and scoot up. There we go. All right, so this is, scoot a little bit farther forward. So this is good patient positioning. She's about the first third to half of the table. The reason you generally want patients here is it makes it easier on you as the doc, because whenever you're looking to get your contact point, you can roll them over just a bit and bring the contact point to you instead of having to lean over to go and get it. It also sets up their leg here so that it's not getting pinched on the corner of the table. It's going to roll right past it, and then whenever you set up, there's going to be a little bit of pressure here, but it's not going to be pinched on the corner of the table. Okay? So now I'm going to have her scoot back and show you what the common error is. Good. All right, so you can see whenever she's scooted back, just to go and get the contact point, even if I roll her a bit, her leg's hitting the table already, so it's going to stop that. But I have to lean much farther over to get the contact point. It puts a lot more strain on the doc, and if you plan on running a high volume practice or performing a lot of adjustments a day, it's going to get really tiring really fast. So the other issue whenever I get set up is her leg is going to be pinched between the table. Can you feel that?
Yeah.
Yeah. So instead of her leg is going to be pinched about right here at the or just above the kneecap. It's going to be pinched in the corner of the table, and there's going to be a lot of pressure there, and that's going to cause her to have some tension because she's trying to relax, and it's just going to make the adjustment a little bit more difficult for you and a lot more uncomfortable for the patient. So again, let's review what normal is. So go ahead and scoot back up. There you go. So now when I roll the patient to get the contact point, I can bring that contact point to me. And then as I set my stabilization leg, my weight can be on the hips without compressing her leg into the corner of the table. So that whenever I stabilize, there's no pressure on the knee pinching it between the table. All right, so the next point we're going to talk about is the patient's head positioning. So believe it or not, this can have a significant impact on their spinal musculature all the way down through the lumbars into the SI. So the two common variations of this mistake are whenever the patient gets set up and you tell them they get set up, and as you're working with your contact, what they're going to do is they're going to look up and back at the doctor. Go ahead and show them what it looks like just so you can see, because they're curious. They want to know what you're doing. They want to know what's going on. This might be their first time in this position getting adjusted. So they're going to be curious as to what you're doing. That's all. They just want to see what's going on. So simple instructions like, if you don't mind, go ahead and relax your head back on your side and then just look straight out. The reason you want to tell them to look straight out is to avoid the second issue, which is flexing the head. So go ahead and flex the head down. So what they'll do next is after you get them to relax their head, they'll try and look down still because, again, they're curious, or they just think that's a more comfortable position. But if you do this to yourself, if you put your hand on your low back, just feel the musculature, and then flex your chin to your chest and rotate, you'll feel the musculature in that area activate and start working, and that's what we want to avoid because there's obviously tension being created there. So if you don't mind, go ahead and bring your head back a bit. There you go, and just look straight up. So simple instructions like that. It's a small detail, but it's going to have a big impact. It's more relevant in the lumbars, especially, but it's still going to have an impact on the SI. So anything we can do to relax all the musculature down here is going to make our job easier, and it's going to make it easier on the patient. All right, so the next area we're going to discuss is bringing the bottom shoulder too far anterior. All right, so with perfect patient placement, we have the bottom leg straight, top knee bent, foot tucked behind the knee, shoulder brought inferior and anterior. But one of the common mistakes when doing that is bringing the bottom shoulder too far anterior, which you can see her rotated this top shoulder back a bit. And what that's going to do is that's going to create tension along the spine because you're rotated versus just having the shoulder brought slightly anterior. And the reason we bring it anterior initially is because lying stacked up on the shoulder like that is uncomfortable. There's pressure right on the shoulder joint, and that's just not comfortable. And the patient feels like they're on kind of a wedge, like they can roll forward or backward. So bringing it slightly anterior takes them off of that. Just think about you laying on your side. You're not going to lay literally directly on your shoulder. It's going to be slightly anterior because you feel like you can relax best in that position. So that's the same thing here. So we're bringing it just slightly inferior and anterior versus like this. You can see the shoulders rotated back. That creates torsion in the spine. That's going to create tension all the way down to the SI joints where we don't want it. We don't want it anywhere, but we're talking about the ilium today. So for that purpose, it's going to bring it tension all the way down there. And we want the patient to be able to relax and have as little muscle tension up and down their spine as possible. So again, whenever you stack the patient, bring the shoulder inferior and just slightly anterior. Bring the pillow down to allow them to relax and be comfortable. And that's how we're going to avoid that mistake. All right, so one of the last positioning areas we're going to talk about is the patient's feet and legs. So a common thing that patients do whenever they first get on the table is they'll go ahead and bend their legs back and dig their feet into the table just for a sense of security because they're not comfortable being in this position. They've either never been in the position or they're just not used to it, and they haven't gone through enough adjustments like this to understand that they won't be dropped off the table. So it's just a common safety thing patients do for themselves. So the easiest way I've found to help correct this is whenever you get the patient's knee between your leg. So I'm going to go ahead and put my legs right here. And I promise I won't drop you. Always tell them you promise you won't drop them. And go ahead and straighten this leg out for me. All right, and then just relax this foot. Just pick it up and kind of wiggle it around a bit until they relax it. A lot of times they don't know they can relax it just because they have, like I said, I haven't experienced this position before. And you'll notice if you have your hand on the back of their hips or their low back, you'll feel the musculature around there relax a lot while you're doing this. The next thing, if this foot, same thing, go ahead and relax it. Just wiggle it around a bit. If they can't relax it, what you can do is say, all right, what I want you to do is I want you to scoot down towards the edge of this table a bit. All right. Good. Straighten the leg out. All right. Come up closer. All right, good. So now their foot is hanging off the edge of the table. It completely prevents them from being able to dig into the table and stabilize themselves if they feel they need to. So it completely eliminates that. And once they realize, again, they don't need that to avoid rolling off the table, they'll start relaxing a little bit more in general. They'll start to trust you more as the doc. So if you find that's happening with your patients, try those, and you'll see it allow the patient to relax a little bit more. All right, so now that we've gone through the positioning areas, we're going to talk about some of the common errors whenever you're going through an adjustment or moving the patient into the proper position to perform an adjustment. So go ahead and scoot a little closer. Thank you. Just set up as a PI. So a common mistake is with the stabilization hand on the shoulder. So the proper position is the MCPs over the clavicle, thumb under the humerus, like this, and you're just gonna lift up and slightly back, almost towards that back corner of the table, until you take out all the slack, and then you're not gonna lose it. So during the roll, a common mistake is people pull too much with the shoulder, and you can see it comes forward. So then whenever you end up getting set up into position, you have to move it back again, and more times than not, somebody ends up just rotating straight back, which is another mistake to avoid. But you lose a lot of the slack, or you gain a lot of slack that you were able to take out before you rolled them. So that's one common mistake to avoid. Another one is during the actual thrust itself, a couple things will happen. Either you thrust with moving the shoulder as well, so it kind of looks like that, and that's going to jar the patient's shoulder, cause some discomfort, and it's going to make the adjustment that much harder, or they're not going to trust you next time because it hurt. Another common mistake is rotating too far back or rotating too far into the patient's neck, causing them to choke up a bit. So you're just taking out the slack just towards the back corner of the table, and once you lose that, or once you remove that slack, don't lose it. Keep that real estate, as Dr. Meisel says, and keep it throughout the rolling to the proper position and throughout the adjustment itself. So the last thing I want to talk about to help make sure you can deliver the most effective adjustment, whether you're going into toll, you're in clinic, or actually even if you're before toll and you're just practicing, you want to practice on the proper equipment, the proper height equipment. Because if you don't, you're going to adjust your mechanics and build those motor patterns in an improper way. And then whenever you find the right height equipment, you're going to be thrown off again. And you're going to have to kind of relearn a little bit. You might have the basics down, but you're going to have to adjust your stance, find your balance. You're just going to have to unlearn some things and then learn the new things. So if you can, find the right height equipment from the get-go, especially while you're just starting to learn. So what is the right height? This is the same for the pelvic bench and the cervical chair. The top of the bench or the top of the chair should hit just below or about an inch below the apex of the patella. All right. So for me, this bench is just perfect. The only thing I would maybe do is raise it maybe a half inch if I could. It's on carpet right now, so it's sinking down just a little bit. So on a hard wood, obviously I wouldn't do that. So it's really still just perfect. You want to find a table that's good for you, again, so you can practice the proper patterns. But for Keishla, you come in the frame right there. So Keishla, for example, the bottom of her patella is down here. So obviously this table is about 2.5, 3 inches too tall. So that's going to make everything more difficult for her, because she's going to have to constantly be on her tippy toes, leaning more forward with her weight to have leverage in the adjustment. So once she gets the right height table, if she was to practice like with something like this and then get the right height table 3 months, 6 months, a year from now, her mechanics are going to be completely thrown off whenever she has to start using the proper height table. So I know it's tricky in school. You don't have obviously the equipment you want, and it's not custom designed for you, but find out which tables are good for your height, and then anytime you're going to go practice, go use those tables. It's going to really make a difference whenever you actually have to start adjusting in toll and in clinic. All right, thanks for watching. We hope you learned something from that, and there's some takeaways that you can start applying right away, or some things you can start working on just to get a little bit better. If you have any questions, please reach out to any of the officers in training. We have a quarterly newsletter that we're sending out as well. So if you have some interest in learning more about that, go ahead and reach out to us and for any questions as well.